NHS Unplugged, Rewiring Healthcare in the UK.
Hi, thank you all. I'm glad you made it to the best panel of the day. I'm in the company of a stellar group of panelists here. So for the next 25 minutes, we're going to be looking at one of the critical aspects of healthcare transformation. And we're going to be looking at the UK as a specific market of interest to us all. So I'm just going to really rapidly give a sense of what we're going to be exploring today. So Ipsos Mori pollster has found that 1 out of 4 Britons feels that the NHS cannot care for them. And when you dig into that particular research point, you realize that the problem does not relate to the accuracy of clinical care, but it relates to the engagement capability that patients have, their ability to access services and then eventually adhere to the clinical plans that emerge therefrom. So in this panel, we are going to explore how technology and innovation are transforming a healthcare delivery, right? So the focus is going to be on the shift from treatment to prevention, the role that AI and other digital tools should play in improving the outcomes that patients register. And we are going to discuss the critical steps that are necessary to streamline operational processes within public healthcare, therefore reducing delays, empowering patients, and moving towards a self-care public policy. So I'm joined by a really stellar panel. So thank you, Michael Bell, so Chair of Southwest London ICB, to Tom, who's had an excellent chat with me before we started, who is a GP and expert in digital transformation. Jobin, a serial entrepreneur. It's great to have you on our panel today. And of course, Professor Gordon, who had a brilliant keynote yesterday and is the CEO of Check for Cancer. So let's jump into it right away. And we're going to start exploring the role of AI and technology in the transformation of healthcare. So I'm going to bring Michael into the conversation right away. So we are seeing the move of hospitals towards a community-based care model. I'd like to explore the role which you see artificial-enabled triage playing in the transformation, particularly of primary care delivery. And I'd like to ensure that this still enhances patient outcomes rather than simply automates processes.
I think it's probably worth putting into context the fact that within the NHS over the last 15 years, we've grown the medical and nursing workforce massively. So we've increased the number of consultants in hospitals by more than 80%. At the same time, the number of general practitioners has reduced by more than 5%. So the challenge in making that shift from hospital care into community and primary care is one of capacity. That's our starting point for looking at how we could use AI in primary care. We're currently scoping out the use of AI as triage for primary care. So within London, we have around about 150,000 GP appointments a day, around 200,000 contacts in primary care per day. So the scale is massive. If we want to increase that activity in primary care and increase the quality of care provided, we need to find a way of increasing the capacity of general practice to respond. One of the ways of doing that is to look at how we can better automate some of the systems underpinning the work of primary care. Be that AI-enabled triage, right the way through to ambient technology, in terms of actually streamlining and speeding up the whole process of record keeping. I think it's really important attached to that we actually look at the work that GPs do, and that's where AI-enabled triage becomes really important. Around a third of all GP appointments in London are MSK related.
Right.
The clinical input of a general practitioner in that space is close to zero. They are purely gatekeepers, demand managing the rest of the system. by using AI-enabled triage and good hubs that direct people to the right care, we can get them the appropriate care at the right time much, much faster than the current system. So it's seen in that whole wider context, Gage.
It sounds to me that scale and capacity, which you mentioned, Michael, are also the economic drivers for looking at AI projects and then computing an ROI based on scale and capacity. But I think that becomes even more relevant when we focus on the right use cases in which AI should be utilized. So I wonder if I could bring Jobin into this conversation at this particular point. So Jobin, I know you've done a lot of work around patient-centric care, and I'd like to explore which use cases you have found to be the most suitable. We already got a hint, right? Michael explained that MSK is creating such a large amount of pressure for demand. And so are there use cases that you have seen which are particularly well suited for AI technology to be embedded in public healthcare?
First of all, thank you so much for having me here. What we have seen, the low-risk use cases have got great adoption. One of the use cases, as Michael well said, the AI-powered clinical summary generation, which has got great adoption, which you have seen. For an example, one of the hospital we working in Lincolnshire, psychiatric hospital. Before we introduced Health Orbit to the hospital, they were taking, the doctors are taking more than 90 minutes for clinical summary generation.
Right.
Throughout the course of 2 weeks, which means the doctor dictates the synopsis, go back to the medical secretary, she populate the information, send back to the doctors to review. That's almost 2 weeks process. By introduction of Health Orbit, they could generate that in 10 minutes.
Right.
Dictation takes 6 to 7 minutes, 1 to 2 minutes, the summary is generated.
So there's no doubt that process automation here is hugely changing the time efficiency within the clinic. But what about the adoption by clinicians? Did you find that the challenge is not so much dropping the technology in the right use case, but the change management process which needs to lead the clinician to effectively utilize that technology?
Which is truly right. In the adoption by the clinicians, they're not really... they don't want to adopt the technology which they don't have a trust. There's a trust deficit which we can see, probably because of the data protections, NHS digital compliance. So if there is an ownership in the hospital, if one of the person in charge, if they take an ownership in terms of implementing a solution,
right,
it seems to us it's working fine. And as you said, the patient engagement, that is the outcome of this clinical optimization. If a doctors have got, what we have seen is more than 10 hours per week, doctors could save the time.
Right.
This is not just for doctors, it's for the nurses too, crisis team.
Right.
So they are saving more time, which means more patient-centered care. They are speaking to the patients, and patients feel more comfortable of speaking to the doctors. And this is the feedback we received from the hospital we implement the solution.
Let's double click on this idea. I'd like to bring Gordon into the discussion at this particular point. You gave the example, Jobin, of how medical summaries have been manually processed and have slowed down the delivery of the particular clinical outcome that we desire. I'd like to move this same topic into cancer, where we have many manual processes which slow down the delivery of care within the cancer ecosystem. I think, Gordon, the question would be this: what is the golden standard or the litmus test that we need to pass AI through to create the right environment for the utilization of AI to give us exactly these productivity gains, these efficiency gains, and these clinical accuracy outcomes that we're after in cancer treatment?
Yeah, that's a really good question. I think it's really important that whenever you're going to use AI, you define what the problem is and you involve clinicians in actually saying, this is what we need help with. And it's really important that the technology is then developed to answer that particular problem. So I think that's important, and if you do that, then you have the chance of bringing clinicians along with you. And because there is resistance, I think secondly, you have to ensure that you're going to access really good quality data, because that's That's going to be your real advantage if you want to produce something that clinicians and patients are going to believe in. I also think that you need to work on explainability if you're going to use NAI. It's really important that all the clinicians understand the output from the model, and so they buy into that. So I think there's lots of things you have to do. I think probably the best example, which I gave yesterday, was recently in breast screening using AI. 2 big studies in the last year that show you can actually improve breast cancer detection by using AI. And of course, breast radiologists have used computer-aided detection probably for the last 20 years. So maybe it's a smaller step for them. So I think there are good examples, but I think you have to follow the general principles if you want to take people with you.
I love the way you started, which is setting a definition first. It's almost like in a clinical environment, we often forget to ask ourselves the very fundamental question, which is, what does success look like? Where is this journey taking us? And I think this allows us to open a discussion about measurability of success. So I'd like to bring Tom into the discussion at this particular point. So through ORCA, you've obviously seen a large amount of applications being brought into the market to reach a particular successful standard. But what about measurability? How is success defined? How is success measured over time with the apps that you bring into the market?
Depending on the app, apps will, and it's the health app market really that I operate in, and different apps will have different metrics. Diabetes apps will be looking at HbA1c scores, depression apps will be looking at PHQ-9 scores, but ultimately what we're trying to do with a kind of at-scale transformational approach is we're looking at patient activation. There was a paper done by the Health Foundation in the UK that looked at patient activation. That's where the patients have the knowledge, the skills, the confidence to self-manage their condition. And they compared patients with a high level of activation against those with a low level of activation. And they found that those with a high level of activation had a 38% lower risk of attending the ED. They had an 18% lower risk of attending a GP appointment, needing a GP, and if they had a mental health condition, they were 50% less likely to need to go to the ED as well. So there is huge gains from being able to digitally empower patients and get them to this activation level. And in the UK population, our population is about 60 million, it was estimated that if you got that low activation cohort up to a high activation level, you could prevent about 500,000 unplanned admissions to hospitals. So that's the success metric here. A patient with a long-term condition will maybe have 10 to 20 minutes with their healthcare team every year. So it's clear that digital tech, which can sit on their arm or their wrist or on their mobile phone, in an age where, get this, there are more mobile phones on the planet than toothbrushes, there is an opportunity for us to empower patients outside of the consulting room. And that's the measure of success for me.
Let's jump off this patient activation springboard, because it's such an important point for us to consider when we look at, personalization of the service. So let me just circle back to Michael, now looking at sort of the strategic leadership of the NHS. So as we are moving, we're seeing this sort of post-electoral shift from treatment to prevention, being accelerated within the NHS. What are the key steps that we need to take? And is there a role for private companies, most of which are in this hall today, to play in this acceleration?
Well, I think Tom has really hit it with the whole of the activation point. So if we want to really make a huge difference in terms of prevention, then we need an active population. If we look at prevention, one of the most effective and measurable pieces of prevention that we have within London is our work on HIV. Within 3 to 4 years, we will be in a place where we are eradicating the transmission of HIV for future generations. Now that's really exciting. What were the components of that? There was a medical component, and the key levels of advice and input that were provided there. There was a pharmaceutical input, be it antiretrovirals or pre-exposure prophylactics. But the really key part of it was the social element. So as we begin to look at prevention, we're looking at how we can wrap that social element around it. And that will inevitably involve technology, and that will inevitably involve partnerships. If I could use one very quick example, within the next 12 months, we are anticipating that within London, we will have more than 1 million people on anti-obesity drugs. That's our pharmaceutical intervention, guided by our medical colleagues who will identify the cohorts that would benefit most from that. If we want that to be sustainable, we have to activate those people that we have put on pharmaceutical intervention. Otherwise, it's a drug regime for life. So that's a good example for me of how we can work with our private partners in the pharmaceutical industry, but also critically in the tech industry to support those communities to have really sustainable long-term prevention outcomes.
I believe that our duty of care to the layer which relates to activation, the social layer as you called it, needs to also frame clinical safety guidelines. I don't think that adoption at the cost of clinical safety is something that we'd want to endorse. So I'd like to bring Tom once again into this. As you represent in the market, through Orca, different apps which we bring for activation purposes, for engagement purposes, how do you parameterize the clinical safety guidelines and standards that you would expect these apps to comply to?
Yeah, great question. I think the first thing I would say is I would just push back and say I don't think it's adoption or standards. I think standards build trust and trust builds adoption. So I think the two are connected. But I would say that the challenge, I think there are two challenges. I think firstly, when it comes to regulation, I think the bar is often not too high, but very difficult to navigate. Regulation's really hard. It takes a lot of investment and time, and that's a barrier to good solutions entering the market. But also, I don't think the current regulation is fit for purpose. I think there are a lot of health apps out there, for instance, that don't quite meet medical device regulation status, and as a result, they're able to operate in the market in a kind of grey area. I mean, if I just ask the audience, of the 350 health apps that are out there on the market, have a think about how many you think pass quality standards. Number is 1 in 5. So if you have a patient or a loved one that goes on the App Store and downloads a health app, you're 4 times more likely to download something that's harmful or ineffective. So I think we need to firstly make sure we're closing the gap and regulating that space. Secondly, we need to reduce the huge amount of duplication that happens in regulation between organizations and even between countries. And thirdly, I think we need to make regulation mean something practically for patients and healthcare professionals. They don't care about an ISO badge or a CE mark. They want a Trustpilot score for digital health technologies. And that's one of the things Orca does very, very well. We assess products and we give them a score out of 100 based on their data security, evidence, and safety.
I almost like this idea that you don't trust technology because it is computationally better, right? Because AI is able to process things faster or more accurately. But you trust technology due to those multiplicity of artifacts that you look out for as a consumer from a product. And it's almost a little bit of a shift in mindset on how we do that. So this is a great junction to bring Gordon back into this discussion, because cancer treatment is also moving within parameterized guidelines to more personalized care, therefore moving away from population-based models toward self-assessed personal cancer risk apps and solutions. So could you take us through the ideal process that you'd see such technology go through to be brought into the market to maintain clinical safety, to obtain trust and adoption by the market, but still provide the personalized outputs that you would expect the technology to provide?
Yeah, I mean, prevention is a big part now of any early cancer detection strategy. I mean, HPV vaccination has had an incredible effect on the incidence of cervical cancer. It's reduced it by 80 to 90%. So it's really important. And I think the other approach to prevention is, of course, cancer screening. Cancer screening's not there just to detect cancer early. You're going to pick up a number of precancerous lesions that would have gone on to become cancerous. So I think we're going to see increasing personalisation. We also know a number of the lifestyle risk factors for the different cancers. You know, that we could all reel them off. You know, smoking, lack of exercise, poor diet, obesity. Now, you can define those. It's much harder to get someone to change their lifestyle to try and reduce their risk. And I think we're going to need good quality apps and support that if we're going to encourage people to do that. But I think on the treatment side, as you mentioned, we're seeing increasing personalisation, and I think that's really important. And I think the final point I'd like to make is that our national screening programmes in the UK are all based on population risk. So that assumes that when you get to a certain age, your risk is enough for you to access screening. And I think more and more we're going to see personalisation of that. If you reach that risk 10 or 15 years earlier, then there should be a screening programme for you. So I think we need probably a wider range of screening programmes and that move from population to personal risk.
As we move to additional personalization, I think there is a correlated discussion around consent, right? Which citizens, which patients need to provide for the data to be utilized in an environment where we can provide personalized output. So I wonder if I could bring Jobin back into the discussion here. I know that Health Orbit has used early insights from patient interactions also to support the preventative and sort of predictive side of healthcare outcomes. How do you circumvent, or how do you manage, rather, the consent issues, especially when you're doing predictive modeling, which has a higher degree of risk than historical modeling?
So we believe AI can play a huge role in targeted preventive care. For example, digital tools allow patients to track their vital symptoms at home. This information can be shared back to the healthcare providers, where the AI can process millions of data points, no time, flag any anomalies that help the doctors to prevent or address or detect and address these concerns and escalate based on the low risk, medium risk, high risk patients. Which means obviously patients are getting treated before this escalated. That's my take on it.
We've got 2 minutes to go, and I've met quite a few public health experts in the room today, which I've chatted with before we started this session. So I think we should give them something special in the next 90 seconds or so. So I'd like to ask each of you a very simple question. We'll start with Tom and move to the left. If you had, so we are in this post-electoral period with the Darzi report influencing a lot of our public policy thinking around healthcare. We've got, the Chancellor of the Exchequer, which has given a generous budget, one of the largest the NHS has seen in a few years. If you had a magic wand and an infinite budget to perform just one corrective measure within the NHS to change public healthcare, to reach the goals we've discussed in these last 25 minutes, what would that be, Tom?
I would like to make it as easy for a patient to download an appropriate digital health tool that supports their self-management as it is for them to obtain an antibiotic or a painkiller from a doctor or a pharmacist. They are as powerful, as effective, and as available. The barrier is both funding and a paradigm shift. That's what I'd use my magic wand for.
And to some extent, we'd want to lower the bar of digital maturity, which is necessary to access those apps, because at the moment it's quite high. Gordon, what's your wish?
I think I'd like to see an increasing use of technology in primary care and in the community to reassure as many people as possible that they don't require any further investigation, and to try and limit the number of people going forward to secondary care so that actually they can cope with that number of people. And I think we can use technology to improve that triage process.
When I look at the sort of political structures across most of Europe, you realize that the demand management and patient waiting lists remain the two largest political problems throughout Europe. So I think that would be a brilliant area to focus on and solve. Jobin, let's get yours.
I agree on Gordon's point. Bringing the technology and help the doctors, nurses to do their job, patient care. Let the AI, let the technology look after the documentations. Let the AI does the preventive care. Everything will fall in place.
Thank you, Jobin. Last but not least, Michael, let's hear it from you.
Well, clearly the three shifts are an important part of that, with the analog to digital, prevention, taking place of treatment, and the shift from hospitals into community. But what I really would like to see costs no money. I would like to banish the word patient and start talking about people seen in the context of their families, their neighbourhoods and their communities, and building our solutions around them as people and them as assets, not as problems to be managed. That's how we make the difference.
What a lovely way to end. What a lovely thought, this idea of being in a community. Perhaps we need to redefine that political norm, that value of solidarity, of leaving no one behind. We do need a public health system that leaves no one behind, that is efficient, that is kind, that has the courage to change in the face of the technology and tools that we have available. So thank you all for being the most brilliant panelists we've had today. Appreciate your time, and thank you all for listening through. Have a great afternoon.